unmute it when I start.
Testing. Yep. So we're getting the Zoom audio right there. And we make sure the camera's okay. So yeah, we're good. Okay. And let's make sure we're recording and all that. So we're recording.
Good.
Captions.
Do you need like is it enough for you to prepare for transition?
So transition and then really
Definitely.
so it's gonna go like
Okay, I just wanted to get sure.
yeah.
Like on this slide advancer setup. Anyone's gonna use it?
Okay, I've never used this before.
Just right is forward and left is back. That's all. Yep.
Great.
And when was again the microphone, or it's already on?
It's already on and it's going to Zoom. Yep.
Great, and it's on Zoom.
Yep.
Okay.
And I'll be right behind this door if anything comes up. But
So do the people are already here now?
it's
Okay.
first in here. Oh, let me make sure I just want to make sure we're sharing the screen for the people.
Yes.
I think the thing I like about the plan. Oh, it's got it. Okay, should be good.
Sharing.
Mhm.
Yeah, we're a small group. See. Ready.
Anything comes up, I'm ready.
Okay. So while we are sitting down, good afternoon, everyone, and I'd like to welcome you back to our last breakout room session of this afternoon. My name is Marcela Bradová, and now I will be handing the presentation to you.
Okay. Awesome. Hi, everyone. Good afternoon. Welcome. Thanks so much for taking the time to join us. I know it's our final hour of what's been a really amazing summit. So thanks for being here. We're super excited and grateful to have such a diverse group of voices and perspectives here today. As we believe these are essential to fostering equity and creating more inclusive spaces. While our time is limited to 1 hour, and I think we all feel collectively that we could talk on and on about gender-affirming care as it pertains to our specific niches within medicine and even outside of it. We hope this conversation, albeit brief, will inspire curiosity and spark more conversations beyond just the summit today. And your participation is most welcome as we progress through this. We hope it'll be a really engaging conversation, and definitely look forward to all the insightful conversations that will come from this. Before we dive into the panel session, I do just want to be upfront and totally acknowledge that I do not consider myself an expert in gender-affirming care. I myself am learning and continue to learn from this group and lots of other folks within our network every day. And so I'm super honored to be part of this panel and am excited to learn more today. I also don't have this specific lived experience, and I want to honor the folks in the room who do have this lived experience and center their voices and that cultural context here in this space. So that being said, I do have a tiny, small passion project of mine as it pertains to the emergency department that I'm excited to share with you all today, and hopefully get fresh perspectives on that too. My biggest goal is to really facilitate a respectful, informative discussion around this topic, drawing insights from those on this panel who are deeply knowledgeable and experienced in this area. I'm really excited to introduce you to each of them. And lastly, I want to use this platform to really recognize and honor the really powerful work that they're doing within our network and outside of it to transform and sustain gender-affirming care in Vermont. So as for brief introductions, I'm Ash, she, hers. I'm an emergency medicine physician. I'm pursuing a global health equity fellowship in emergency medicine, and my locally minded work focuses a great deal on building gender-affirming care models in emergency departments, not just within UVM, beyond in the network, and then hopefully on a regional, if not national level. I currently split my time at both UVM and a very small, teeny tiny 6-bed critical access emergency department in upstate rural New York called Elizabethtown. And then next, and I'm going based off of this here sheet, if you don't have access to this. This has all of our little intros. Next, I'll introduce Anya. Dr. Anya Jokala is an assistant professor at Larner College of Medicine and a family physician at UVM Family Medicine South Burlington Clinic. Her practice includes primary care for patients of all ages, obstetrical care, and care for gender-diverse individuals. Dr. Jokala stewards the Gender-Affirming Care curriculum through the UVM Family Medicine Residency Program, and she also facilitates a regional gender-affirming care provider working group. Next, we have Emily. Emily is a labor and delivery nurse educator at Central Vermont Medical Center. They're also a registered nurse and lactation consultant on Baird 7 at UVM. They have a personal and professional interest in working to expand nurses' ability to provide affirming care, especially in the traditionally gendered specialties of birth and lactation. And then we have Megan Roberts. Megan is the transgender program health and wellness advocate at Pride Center of Vermont. She is a former paramedic, has worked in both pre-hospital and ED settings, and has lived experience of gender-affirming care as a trans woman. So super honored to be part of this panel. And now that I'm up here, I will just briefly go through my emergency department project and where it's currently at. So it's titled Creating a Gender-Affirming Care Model in the Emergency Department. And really what started this project for me was reading about several really glaring statistics back in intern year that really struck me and motivated me to learn more about this. And from there, it really became a passion project. And I was able to collaborate with great mentors like Dr. Katie Wells, who you've seen today, to be able to build this in our emergency department. So some of these statistics are as follows. So 1.6% of the US population currently identifies as trans or non-binary. If you were to tease that out a bit more, 0.6% of the US population identifies as trans. That population has 3 times the rate of suicidal ideation. 81.7% of gender diverse Americans have seriously thought about suicide. 42% have attempted suicide. 2/3 are diagnosed with MDD or major depressive disorder each year. 20% are blamed for their health status each year. 50% report having to educate their provider about their care. And 22% avoid emergency department or ED visits altogether. Lastly, 29% are denied healthcare access outright. And I remember reading this in several papers as an intern and feeling incredibly frustrated, and that led me to basically do a deep dive in the literature to look at medical education and where the gaps are there. And it doesn't get any better. A total of 4 hours in all 4 years of medical school is dedicated to teaching about LGBTQIA plus healthcare delivery. And it gets worse from there in residency programs, specifically in the papers I've read based on emergency medicine, which is my specialty. Only an hour is dedicated to that through didactics curriculum, whether you're in a 3-year program in emergency medicine like I was, or a 4-year program. So all of those things combined motivated me to look further and see if there were any current models that were working on building affirming care, continuity of care in the emergency department. And so that essentially led to my project, which its goal is really simple. It's just to improve the overall care trajectory and healthcare delivery of gender diverse folks in the emergency department, from registration and triage, which is statistically known to be the most traumatizing aspect of an emergency department visit, all the way through until disposition, which in our terms is essentially when we decide should the patient be admitted or are they safe to be discharged. And so for me, that has multiple different subtypes or sub-goals, essentially, that include examining the prospective healthcare delivery for gender diverse folks in the ED, assessing the structural barriers and medical gaps in education that contribute to health disparities for gender diverse folks in the emergency department, we specifically did this by creating accessible QR code surveys that were distributed in our emergency department and accessible to all patients who are being treated in the ED. And we did this at various times, 7 days a week for just over a year. We're able to collect, I think, close to 150 responses. And then they were accessible by QR code. They could fill it out at their leisure or with one of our research assistants who was happy to guide them through using the tablet and asking them questions directly and filling them in that way. And then likewise, we distributed this out to the community through amazing partners like Vermont Pride Center and Outright. And then we also created provider surveys and ED staff surveys to be able to better identify how their practice is currently going, where they're seeing any gaps, where they want to learn more. And it was an opportunity for us to be able to identify any areas of improvement within the overall care trajectory while they're in the emergency department. And thankfully, we had, I believe, 95% of all ED staff, including providers, filled it out. And that included medical students rotating through at the time, residents, nurses, mental health techs, ED techs, residents and attendings. And then from there, our big goal is to collate all of that data, learn from those survey responses, which a lot of it was quality improvement responses. There were a lot of fill in the blank opportunities for folks to really share what their experiences were, positive or negative, while in the emergency department, taking all of that and bundling it to essentially create a simulation curriculum to enhance the core competency in education to promote equity and improve outcomes in emergency services. And when I say simulation, for those not familiar in the room, this is like a big tool we use in emergency medicine specifically to enhance our learning. In my residency program, at least, we did it every other week, and we did it for about 2.5 hours at a time. And the whole idea is you're working in a safe space. It's low risk. And typically those cases deal with a mannequin, which you can basically think of as like this tiny robot that is controlled by folks in the back of the room who have a whole script. The patient can talk to you and tell you they're here for chest pain, and it's really your job and the rest of the team, whoever's included, and typically it's a bunch of residents, intern all the way through until they're considered a senior resident, working together to essentially solve the case, do an appropriate workup, get the patient the correct disposition, and keep the patient alive. And typically that's translated in things like the patient's presenting with chest pain, and it's the team's job to identify the patient's having a heart attack and go to the appropriate labs, get the correct testing done, initiate the treatment plan, call cardiology. Here, what we've done is essentially expanded out from that core idea and have now applied it to something like approaching a patient who identifies as gender diverse and is presenting with abdominal pain. And this was a case that was reviewed by multiple folks in the community, and then members of our simulation team who identify as trans and non-binary, getting as much perspective on this as we can, and then using literature that does exist in medical education in terms of simulation to build this in a way that is reflective of people's current experiences in the emergency department. And so that is our simulation plan. And then ultimately want to use all of this to build a better increased core competency in the emergency department so that when they do have the opportunity to interact with their next patient on shift, it's something that is successful for the patient and optimizes their care delivery. And so that's essentially the project. And then, like I said, trying to build it better from registration all the way until disposition. Registration specifically, we've worked really hard to create standardized intake forms when collecting any sensitive demographic data. And that's something that's applied to all patients. The expectation is that this will be available and will be the script for all patients as they're checked in to the emergency department. And then relaying information that's collected in real time by registration folks into the ED chart so that it's translated onto, we use Epic, which is our electronic medical record system, to project onto. We have giant track boards in the emergency department that allow us to see which patient's in which room, and we all have access to that. And so having the clear facts as the patient stated it, name, gender identity, pronouns, all of those things. So it's all bundled. It's right there. We're not re-traumatizing patients, especially as multiple learners and different roles within the emergency department go in and out of those rooms all day long. So that was a big moment for us. And then using simulation, and then a recent thing we've done to enhance our simulation experience is work with an ethnographic storyteller, a very incredible filmographer named Ned Castle, who works locally in Vermont and has tons and tons of really incredible footage working with ethnographic storytelling, which is essentially meant to document someone's lived experience and help other folks who do not share that lived experience have a better understanding of why this is a critically important issue. And so the hope is, and some of our panelists have been involved in those filming today with the whole understanding of like allowing folks to really get insight into why this is an important thing. And then using all of that to ultimately train a core set of folks to distribute this out, not just within UVM, where we have all the bells and whistles and access to lots of resources and specialists, but beyond that, in tiny emergency departments like my other one in Elizabethtown, that's 6 beds and 2 nurses and a doc. And so the hope is to be able to use this as a launching pad to allow other smaller hospitals within our network, and then hopefully beyond, have access to this training as well, to enhance competency across the network and beyond. And then working with folks in the community, as well as partnering with other specialties like family medicine, OB, and having a really multidisciplinary approach to this, and primarily a community first approach, and moving forward to build this. And so that's a quick recap of what's happening in the emergency department currently. Excited to see how all of the data turns out, and then see how the simulation unfolds. And then definitely want to acknowledge and thank this group of folks that's included here. And yeah, I'm happy to take any questions right now, if anyone has any about this specific project. Otherwise, I was planning on passing the mic off to Emily, and Emily's going to chat with us about their project as a lactation consultant and registered nurse. So if no one has any questions for me right now, I'm happy to pass it off to Emily. Awesome. Okay. Great. Thank you. Yeah.
Hi, everyone. My name is Emily. So I'm just going to kind of briefly cover the project that I did up on Baird 7 and labor delivery at UVM Medical Center. So this project was born from an experience I had while training to be a lactation consultant at UVM. It was my first day actually in the new role, and I had an experience where we had these amazing seasoned lactation consultants who, for the first time, at least in their career, were faced with a family who had received gender-affirming care and really were at a loss for how to provide lactation support to this family, to this specific patient. And here I was as a brand new lactation consultant, but having my own experience and the experience of my community, kind of had an idea of how to navigate this specific clinical experience. And what it showed me was that there was a real need for very targeted education on how to provide care to folks, this population who has not really been educated to, especially in healthcare. So that's where this project came from. And so I initially was just going to provide education to staff, but I saw it as an opportunity to gather some data. And so I kind of went on this journey to build a pre-education survey to assess nurses' confidence, their self-reported confidence in providing lactation support to gender diverse populations, specifically who have received gender-affirming care. And so at a combined ed day between the antepartum, postpartum units and labor and delivery, I was able to administer this survey. And then a year later, I was able to administer targeted education on this topic and then follow up with another survey at the end of that education day. Did I go too far? No. So the survey itself was composed of 8 questions, each posed a different scenario around gender-affirming care specific to lactation. And so each question, we asked nurses to respond with their confidence level. I used a 4-part Likert scale to try to weed out any people that want to be neutral. Really trying to ask people to address their own confidence and look at yourself and say, are you confident or are you not? And there was, strongly disagree all the way to strongly agree. There was a little bit of nuance in there. And these were the survey questions that I posed to staff. So questions about using inclusive language, providing lactation support to folks who have practiced chest binding, had top surgery, chest augmentation, have ever been on hormone replacement therapy, plan to continue or restart hormone replacement therapy. We're in the process of inducing lactation. And then finally, I was trying to get a sense of how much anxiety or worry kind of plays into folks' inability or lack of confidence in providing care to this population. The actual presentation of the education, I initially wanted to just kind of go brass tacks, nut and bolts, like let's focus on lactation, but I saw that we really needed to take a few steps back and address a base knowledge deficit that seemed to exist in terms of like what types of gender affirming care would our population potentially have undergone, so that we could create context for the lactation side of it. So I really focused on health disparities that are associated with this community or this population, the impact that nursing can have in both directions on providing affirming care, and then specifically the types of gender affirming care that our birthing and lactating patients may have received, and finally how to perform lactation specific assessment and patient education based on each type of gender affirming care that we may encounter in our specialty. So the survey, I really wanted to see if this type of education, or I guess I wanted to prove that this type of education was effective. And so I parsed out the data for each specialty, so labor and delivery, and then Baird 7 is our antepartum, postpartum. And so on the left, we have the pre-education surveys I administered. I think there were about 98 that were completed, and I think I kept like 95 of them. They were valid. And so anything green suggests nurses reporting their confidence, that they do feel confident, whether strongly agree or just agree. And then the orange suggests that people are lacking confidence. And each one of these represents one of those 8 questions. And then on the right-hand side, we see the responses afterwards. I think we collected 89 surveys, but people tried to trick me and be neutral. So I had to get rid of some of the surveys. So I believe this represents around 71 respondents. And so for our antepartum postpartum unit, with the exceptions of question 1 and 4, which address using inclusive language and chest augmentation, we saw that nurses reported higher confidence following education from anywhere between 9 percentage points all the way to around 20 percentage points. And then for labor and delivery, we actually saw quite a bigger jump in the increase in nurses reporting that they feel confident providing lactation support in each one of those areas. And finally, I just combined the data. So it's just those 2 slides that you see combined together. So no surprise, based on those big jumps, especially in labor delivery, we see improved confidence over that combined data as well. This does represent healthcare providers' self-report of confidence. This does not actually reflect competence and does not reflect the experience of the people that are receiving care from nurses. However, I do think that this suggests that we have room for a lot of growth, and targeted education can be really effective in providing more competent care providers to our community. From here, this is just, lactation is such a specialty, it's such a focus. I would love to see this more targeted education be replicated in other areas around the hospital, but especially in obstetrics. we have questions from anyone about this? Okay. Alrighty. So, oh, we have Zoom. I forgot there was Zoom happening. Okay. So that's the entirety of my bit.
I think now what we do, we did, Megan was very kind of create a box where folks could submit questions in advance of this panel session, with the big goal of just promoting equity further and allowing to hear for multiple voices in the room, perhaps folks who don't want to like raise their hand and ask these questions, that we're able to get some questions submitted, and so wondering next what we can do is get through those and maybe take a stab at answering them. Although we feel I don't. Yeah, it's sorry. Sorry. Yeah, let's move to share. Yeah, talk. Yeah. Don't do that. Sure. Okay. I'll share. Anyone? Sure. Let's see. Can do that with the audience. Yeah, that's true. Go to the audience.
So we have 4 questions submitted in our little box, the registration desk. And I guess it would make sense for each of us to answer one of those. So I'll leave this one for one of you all. So a question from someone was how to introduce yourself to a patient and as pronouns. Hi, my name is Megan. My pronouns are she, her. What are yours? It's kind of easy. Like there's no like magic formula. You just ask the question, right? I think if we normalize using our own pronouns and introducing ourselves to other people, whether or not they're trans or gender nonconforming, like for all patients, like why not? It's not that hard. Put them on your name tag. Allow them to come out of your mouth when you speak to people. That makes it much more acceptable for everybody. To... Sure, go for it.
Yeah, agree. This is such a simple thing to integrate into how we approach patient care. But even in my anecdotal experience as a resident and now young attending, that is something that is not the norm and is not happening, especially not in the emergency department. And that was quite glaring when I looked at the statistics of even that survey. The preliminary results coming through were shocking. Folks are acknowledging, providers are acknowledging, this is a really important thing, and we should be talking about this. And I should be doing that every time I walk into the room, regardless of how the patient is presenting, regardless of for what. I should be saying, hey, I'm Dr. McCormick. You can call me Ash. My pronouns are she, hers. What do you like to be called? What are your pronouns? And that's just not happening. And I think the specific statistic for our UVM emergency department, and don't quote me on the exact numbers, I'd have to look back at the data itself, but it's essentially saying over 90% of providers, and we've got 65 attendings in the emergency department, are saying, heck yeah, this is really important. Only 20% are going in the room and initiating that conversation by saying something similar to that scripted version of what we just chatted about. And most of that is coming from residents who, through revamping the curriculum and didactics, have had this education and are feeling motivated to use it, which is inspiring, but also trying to get the rest of the group on board is something that's lacking, and just being completely vulnerable from our ED perspective. Yes, Cal.
First, I'm going to just see this. What's a lot? All of them. Error. Yeah, it's moving on.
As someone who works, I mean, I think we all work with families, but as someone who works with people who are entering into creating a family for the first time, there are more than just pronouns that go into it. You know, people like to be labeled as a parent in very different ways. And that's a really nice way to go into that conversation too, where it's like, what do you think you're going to want your children to call you? Or what do your existing children already call you? And same with grandparents and the support person. And it's part of a wider conversation that, you know, brings in identities that go beyond pronouns as well, and in a way that people like to self-identify. So, your next question? Yeah. Cheers.
I want to take, what do you do with gender on? I can jump into how do you define gender affirming care. I like that it's how do you define gender affirming care? Because I'm going to speak from me. There's probably like some multiple formal definitions out there. I most broadly, gender affirming care, in my perspective, includes everything from having a trans competent provider to having intake forms that are inclusive of all identities, having bathrooms that are inclusive of all identities, having spaces that feel comfortable for everyone. That's a space where everyone of any gender identity is welcome. And of course, we can get a little bit more specific, thinking about gender affirming care as far as interventions. And even that could be fairly non-medical. It could be someone who you go to your pediatrician and a child expresses they're exploring their gender. You can talk about some the idea of a social transition, names and pronouns, change to dress or chest support or binding, not medical therapy necessarily. And then thinking a little bit more intervention-wise, thinking about gender-affirming hormone therapy, which I think is what most people think of when they think of gender-affirming care, which would be providing medications and hormones for gender affirmation, and then included in there surgeries and other more complex interventions. So that would be my definition of gender affirming care, and I welcome any other additions to that.
Why not? So gender affirming care, like think about your own life and your own visit to your own healthcare providers. Like you probably don't think about whether something validates or invalidates your gender or your lived experience as somebody, but when you live as someone who's trans, pretty much any interaction in any part of the healthcare continuum can be traumatic, can not be gender affirming. You know, you go to the dentist, I don't like going to the dentist. It's a very vulnerable time. You're in the chair, you're covered in a gown, your mouth's wide open, and you can't really speak. How do you advocate for yourself in those moments? So you need an understanding and a trust level with your provider that they see you for who you are. You don't have to define it for them. You don't have to, currently advocate or constantly advocate for or like correct them. You want them to be competent in knowing who you are and treating you how you want to be treated and seeing you for who you are as a human. Like most cis straight people don't think about this. But when you're trans, every single healthcare interaction comes with fear. Like every time you go to any healthcare provider, like you're on edge that something is going to happen. They're going to invalidate you. They're not going to believe your experience. So gender affirming care for me personally is any part of the healthcare system that I feel safe, comfortable, seen, and well treated in.
Do you have a question back there? I wasn't sure if you were just playing with your hat or if you had a question.
Hi, hello. Hi, and hello. So when it comes to gender affirming care, I do like how Megan brought up the aspect of cis straight people when it comes to gender affirming care. I do acknowledge gender affirming care to those cis straight individuals because I see cis straight women getting breast augmentation. I see cis straight men getting hair plugs as gender affirming care because they're trying to fit into their own bodies. So how we're dropping up that aspect of what you're doing is gender affirming care, even though you attribute it to trans individuals.
I think that's really important to validate that when people talk about gender affirming care, we think, that it's only for trans folk and that it's not already happening and that cis people can't relate to being affirmed in their gender identity. And And I think about, you mentioned, breast augmentation for cis women, and how basically you can just call up a surgeon and schedule yourself for surgery. And if you're a trans woman, you have to get 2 letters of support, and you might need to be in therapy for a year, and you have to get your insurance to cover it. And it's this whole, rigmarole, when in reality, we all do things to affirm our own genders all the time. So I don't have an answer, but I really think it's an important question. And I just, outside of my professional life, I do bring this up when people are like, I don't understand. What do you mean? Like, that feels uncomfortable. And we say, hey, these are things that you do that affirm your gender. And this is the same for everyone else.
I want to add to that one more thing that I thought about. Like, don't treat trans people like being trans is a comorbidity.
So I'll go to our next question, if that works for folks. I like on. Yeah.
Thanks. Sorry, I do have to take off in just a minute. One thing, kind of bouncing back to the pronouns, one thing I've been asked a few times, I've had challenges answering is doing certain training. Staff will ask me, like, so if I understand I want to ask about their pronouns, but a lot of our patients are like in their 60s, and so they're making assumptions based on age. Like, they feel very comfortable asking a 20-year-old what their pronouns are, but they're worried that asking certain demographics might alienate them in the care they provide. So they're more nervous to ask, like, I mean, to be honest, probably like the 60-year-old guy with the Trump hat, what his pronouns? I'm generalizing, of course, but yeah. So I think that's a challenge I've heard from a lot of people. I'm just curious if anyone has experience with that, like how you navigated that if somebody did have a bad reaction to you asking the pronouns, and any tips I could pass on.
I typically work with a population that's within a certain age range, but I sometimes get to work with some off-service patients. And I think there is something that is so nice about our documentation systems that we use that have these things built into them. And so, when I'm going through my admission process, I always ask about pronouns and gender identity and sexuality. And, if it has never been filled out before, I really go through point by point, but if it's already in there, I like to still talk about it. I acknowledge what I'm seeing in their chart and ask if anything has changed. And when people have given any, pushback against that, which has not happened often, I simply am like, this is an important part of our admission process, and we just want to make sure that we have the correct information about all of our patients. And I tend to leave it at that, but just acknowledging that it's important and it's an important part of our practice, and hopefully that this is something that they will continue seeing replicated outside of just their interaction with me, so that it, is not this thing that one random nurse at CVMC happened to say to them, but that it's actually happening over and over again, because it's an important part of, identifying our populations and our patients.
I will say also that's a teachable moment for that patient that you're asking. If they have a reaction to that, like, what do you need to know that for? Like, it's a moment to explain why, and to, maybe make them feel what it's like to have that questioned.
Yeah, I feel like I see this a lot in the emergency department quite often, and I've had experiences as a resident interacting with folks who, like you're describing, not to generalize, but like 60-year-old white dude, Trump hat, me going in, asking pronouns, them getting defensive or asking why do you need to know this? And again, agree with Megan, it's a huge area, an opportunity for education of just saying, this is what I ask every patient. It's important for these reasons. And so if I ask again, what do you prefer for your pronouns? And then it becomes more of a conversation in the same vein as me telling patients, hey, so sorry you're having these symptoms today. This is what I'm worried about when I'm hearing you describe your chest pain that way. This is the workup I'm planning on getting. It's a conversation in the moment with that patient at the bedside. And I think that's something, especially in the emergency department, that can often be lost on folks as we're trying to I hate this term, but like move the meat and see as much volume as you can. It's important to still have those bedside conversations with real humans who are there for very vulnerable, real things in those moments. And then going back to electronic medical record stuff and how that's captured, that's been a huge focus of our group too, because we're seeing that basically it's not always concordant how it's documented in the chart and in real time with all of those things being dynamic. And so this has often become like a point of tension in our emergency department with folks relying on that and it not being accurate. And so that's what's motivated us to really go back and work with registration to capture it in real time as they're coming to the emergency department in that time frame and in that moment, and checking again next time they present, and having it be like a continuation of this conversation, because all those things are subject to change, and it's important to continue to check in with those things. And so that's been a big thing. And then we're trying really hard in our group to even remove the like auto-populated parts of notes that capture based on the current way it's documented in the chart in Epic. So for example, if you have a patient and in the chart it's written as pronouns he, him, it'll auto-populate in our emergency department note. And we're seeing that as being a deeply problematic thing where patients are being vulnerable and sharing, hey, had really great rapport with my provider and my care team, and then got home. And now that I have access to these charts and reading that they totally misgendered me the whole way throughout the note. And now I totally don't want to come back to the CD. And so that's been something we're trying to reshape and remodel too. Anya, I don't know if you have thoughts from PCP perspective.
I have several thoughts, but any other questions? You can expand to other things too. I'm going to say that I come to the asking pronouns. I feel like I kind of have an easier time because people who see me for gender care expect it and know that I'm affirming, and most of the other people are like my patients and I kind of know their pronouns, so I haven't gotten an ideal flow of asking pronouns. So I'm going to say I could certainly be better at asking my colleague patients pronouns. And I will say there are a few instances where I know someone's coming to me for gender care and I feel like I shouldn't ask their pronoun because I feel like I'm prematurely asking someone to out themselves in a way that I'm not certain that's like the way to start our conversation. And I love other people's input, but there's, a handful of times when I've sort of like thought about it. And then I'm like, I'm just going to wait and a little farther into our conversation, ask for pronouns because I feel like that might be a little too direct, a little too quickly. So, but also another thought as we're having this conversation, I'd love to see some population-wide data on how people would perceive being asked about their pronouns, because we can all theorize that a lot of people are going to be offended. Maybe in reality, like everyone's like, oh, that's great. Cool. Yeah, I'm glad people are thinking about this. My cousin's trans, and like, I'm glad to be the cis person who's like, yeah, cool. He, him, she, her, and no big deal. So those are some of my thoughts.
So maybe I'll go to one of our next questions if there are any in the audience. How to call in and call out colleagues who misgender someone else. I think we all like work in different ways and interact with people in different ways, maybe just based on our work. So as a nurse, I am doing a lot of patient-facing work. Like most of my work is at the bedside, and as are my colleagues. And so if I'm in a scenario where one of my colleagues is misgendering a patient, like I take that pretty seriously and I really address it head on. Because it's deeply impactful and we know that it's deeply impactful. And this is something that comes up time and time in obstetrics, is that we use very binary, very gendered terms to describe our patient population in a way that people, it's not even in the front of people's minds. It's just like, I'm working with this person that just gave birth. Everyone gets called mom. Everyone is mom, and that's so problematic. And so that's something that I typically will address head on with people. And I also try to, lead by example as well in my own language, because I think that there's a little bit of just not having exposure for some of my colleagues, and it's just they haven't heard people describing our patient population by calling them like the birthing patient, or like, you know, by their names alone. Like, that's just call someone by their name and you've solved your problem. But I do think that one, addressing it head on, especially in healthcare when we're talking about patient interaction, is critically important. And then also continuing to demonstrate how to use language that does not put people in the binary is another way that you can be a really powerful advocate within your workplace.
So my growth is I have a harder time calling people into conversation. Outside of sort of social work job hat over here, in my personal life and all sort of DEI work that I've done, I've had a really hard time with calling people into conversation. So I'm hopeful you could give me some tips and tricks about that, because I get very defensive, I think, and really more protective. And I want to stop the hurt in the moment when I experience someone being hurtful and using words that are unkind or inappropriate. And so I'm doing more calling out, which I realize definitely has its downfalls. So I'm hopeful in this conversation, maybe you could help me figure out ways to navigate call-in conversations versus just calling out, because I get a little spicy, is what I would say.
Thanks. Sorry. It's really quick, but I'm Slade. Hi. I don't know if folks in this room are familiar with Loretta Ross, who was an amazing activist and just a big inspiration of mine, but leads an amazing training called Calling In the Call Out Culture. And I just want to uplift that training, that learning, Loretta Ross in general, but definitely, I can't speak like too much to the exact things that she shares because I would leave it to her. But I was able to attend that training, and it was really informative in terms of like helping me have the opportunity to learn about the difference between calling in and calling out and ways to approach both scenarios in different contexts. So shout out to her and to her work and to her training, Calling in the Call Out Culture. Thank you.
Are there any more questions? Okay.
Going back to your project in the ED, were there any, I can imagine it's like a litany of problematic things for the registration process, but were there any like key points that you were able to like really hone in on that were problematic within the registration process that you came up with?
Yeah, totally. So
A number of them. But the one that I think is most striking, and why I bring up electronic medical record system, is the traumatization of folks in registration triage nurses, looking at the name in the chart, calling for that patient in the waiting room, and ultimately really dehumanizing that person, and then them having to come to the front, identify themselves, say, correct them, or maybe not, and just leave, is probably the most problematic part of that, based on the data that we're getting back. And then also the issue of timeline and frequent ED visits and those things being subject to change, and lots of education around how it's still really important to ask people those things every time they come in. It should just be the norm. We're asking your name, your pronouns, how you identify, just like I would ask your street address if I'm a registration tech working. Thanks for asking that.
I will add to that, as a paramedic who brought patients to the ED. We would have asked these questions already. I would, for sure. And I would, roll up to the registration desk to bring my patient into the ED with all this information already at hand. and let the registration people know. And I understand the fact they sometimes have to hear it from the patient's mouth. But I'm telling you, this person uses these pronouns and this name. Like that's information that a lot of times, or when I'm giving a report to the nurse, no interest. Because all they have to do is get the person roomed and they've got 5 other patients and they're like way too busy. But it matters. Like take that 30 seconds, take that time. Listen to what you're being told by people who have actually already done this work for you and treat that patient like with a little respect because they've already been through this hard time. They're already going through this crisis. I mean, hell, they're in the ER. They're not having a good day. The last thing they need is to get misgendered and dead named. Like, yeah.
And in medicine, we already have so many things that we ask every single patient that we see. Like in my specialty, I have my assessment, I have my question rundown. There's so many things that I repeat over and replicate with every patient. And that's true in the registration process. If they're asking you for your insurance card, has your insurance changed? Like, why is that a question that's easy to ask every time, but these other ones aren't easy to ask every time? What are your allergies? There are certain things that we ask incessantly of every single person, even if they have multiple appointments in the same week. And so this is simply another thing that we can ask in the litany of other things that we're already asking people over and over again. Is, I guess, my sometimes why I have a hard time. It's like, this is our job to ask a million questions. Here's one more. It's not that hard.
And that totally goes back to even Kel's point earlier, like the more we just normalize this and ask these questions regularly, the less of a barrier it will be when we're like faced with this in real time on our next shift. Like, let's just normalize it. This is what we ask when we're here. We do it for everyone. And that should be the standard of care, period.
I'll also say that something that I don't know if you all do. I know that Cal and I have spoken about organ system inventories, like self inventories of your own organs. Like if I show up in your ER with abdominal pain and you're not asking the right questions, you're probably going to run a pregnancy test. Do you need to? No. Like if you'd have asked me the right questions, you would know I don't have a uterus. But those questions aren't getting asked, and it's leading to trauma being caused to patients because assumptions are being made about their gender. And you're going down a workup path that really might not apply to that person because you've just assumed. So ask those questions. Like, go through that organ inventory with that patient. It'll make all your life so much easier. Cal, would you like to talk about organ inventory?
Flexibility, like invest in ectopic pregnancy. So having one organ screening, you'll be able to know what organs are in that body that might be problematic. That's useful for all bodies. So that it is a gender binary. That's what we got to talk about.
I really appreciate the panel. I really appreciate your point, Doc, about sensitivity of questions of. I work in pediatrics. I'm a spiritual care provider. So I'm trying to imagine myself walking into the ED, and I will admit, I don't use pronouns. I don't ask people their pronouns. I actually don't work in the ED that often. I actually work on other inpatient units. And I'm sitting here wondering, why don't I do that? Why don't I do that? And I'm feeling affect right now, just thinking of getting someone into a difficult conversation in front of their parents. Like all the kids are there in front of their parents. And so I just throw that out there as a topic of discussion. I'm not asking you to solve it, just naming my own affect and mystification around that.
No.
Ask that young person, ask them the whole matter. Yeah.
They'll tell you what pronouns they're comfortable with using in front of their family. So that people-centered care, especially with young people, sometimes we overcomplex what care for young people looks like and people that are over 18. And a lot of it's the same belief. People respect the language that they're asking you to model and mirror back to them. So trust them that they're going to tell you the pronoun that they're comfortable with if you ask in front of their parents. Absolutely, please and thank you. Thinking about interpersonal violence, especially in families. Again, it could be adults in partnerships, that would be unsafe for them to hear different pronouns. So again, don't think just for young people to do this, for anybody. when you have them in a one-on-one, that's a great time to ask, are there other pronouns that, like, I'm gonna say for space to be using with that wouldn't be okay in front of your family? But thank you for being cognizant of that, and you know that violence is like an all ages issue.
Just adding that too, with you know, the under 18 cohort that might have their parents have access to my chart, and they often show up at their visits on their own, and it's certainly tricky to figure out what to document and what not, just to make sure that you're not inappropriately outing anything, whether it's about their gender identity or about their sexual activity or their drug habits, you know, whatever. So it's definitely something that we have in mind of kind of like, how do you balance the privacy versus kind of accuracy.
So as we're nearing to the end, we have time for one more question. It's if anybody who joined us online has a question, now it's the time.
Yeah. Would it be ethical to not share a note? Because there is an option to not share to my chart.
Yeah. And you have to like answer a couple of follow-up questions of like why you're not sharing. So I've not really pursued that. But it's tricky because I find myself not documenting parts of a young person's story, and then I kind of have to ask it again. So like I wish there was a place where I could do that. Psychiatry is all sensitive, but then there's places like reproductive endocrinology that I think should be a little more sensitive that aren't. And primary care, we talk about a lot of sensitive things. I don't know. So it's not a perfect system by any stretch. But it's a good reminder that we could have that option if we really wanted to talk about like, you know, something that a patient was very direct they didn't want to have shared.
It concludes our session here today. Thank you so much for joining us here. Thank you again for our speakers. And we have the last session, which is together at 4:10 at the Lake Champlain Hall. See you there. Thank you.
Just love to make it accepted. But I believe I don't think it's all around when your parents and we have even things very well. It's checked it out. But